Thank you, sir, for this wonderful insight on IgG4 related disease. Thank you, Dr. Ubaid. Now, next 12 minutes, I'll be giving insight on clinical pathological cases of retinoblastoma. I've selected a diffuse retinoblastoma. I do not have any financial interest in any of the material discussed here, and this is purely an academic one. The case one was 5-year-old female from South Assam and presented with blurring of vision in the left eye with floaters. She was referred from Silchar Medical College with a diagnosis of intermediate uveitis. Now, she was adopted child, second baby, no complaint in infancy, and vision was 20/20 in the right eye and 20/30 in the left eye. IOP was raised in the left eye. Now, when we saw the slit lamp, there was certain deposits in the eye, in the anterior chamber, and the seedings were not seen, and you can well appreciate their pupil was constricted. Immediately we have dilated the pupil, and you see there was a endophytic retinoblastoma, which is a whitish colored lesion, 9 into 10 mm it was documented. There was a mild hyperemic disc was noted in the right eye, and other eye was within normal limit. B-scan ultrasound was done. So because of the no comment was made on the intraocular mass, sonologists felt the child was uncooperative at this point of time. But when it did the anterior segment OCT, there was a deposit in the anterior chamber along with the seeding on the posterior surface of the corneal endothelium. The provisional diagnosis was made anterior chamber retinoblastoma seed and group E retinoblastoma, endophytic growth with vitreous seeding. Secondary ocular hypertension. In the right eye, there is an optic disc hyperemia. Otherwise, the eye was normal. In MRI scan, it showed 8 into 9 mm lesion abutting the inferior lateral globe wall on the left side with flecks of calcification without optic nerve or extraocular spread. The examination under anesthesia confirmed the clinical finding. Patient was sent to local cancer institute for 3 cycles of chemotherapy. Now, the patient did not improve, the anterior segment seeding did not improve in spite of 3 cycles of systemic chemotherapy. So we decided for enucleation in the left eye under general anesthesia. And this patient, this is the enucleated eyeball with a long optic nerve stump. You can see the deposits and seeding. This is a transillumination depth, and this is a cut section showing the tumor, and this is a Bradloff technique showing the tumor. Now, these were measured accordingly, and most important dimension, the basal diameter of the tumor was around 12, height was 8 mm, and maximum thickness was 7.8 mm. Percentage of vitreous cavity involvement was around 40%, and distance from the anterior edge to the tumor was 0.3 mm, and distance from the posterior edge to the optic disc was 7 mm. Now, these are the different end phase and the gross specimen documentation of the retinoblastoma case. These are all deposits, and this you can see in the cornea, the isolated seeding can be seen. In raw specimen cornea, you can see the seedings as there, and in the corneal endothelial cells along with the seedings were evident. Now we see the single seed of a retinoblastoma from which the individual cells are percolated inside the cornea, which was documented. And central retinal pigment atrophy was seen in retinal raw specimen with a fluorescent stain. This we had published that there is a atrophy in the central area because central RP has a nucleus there. When the chemotherapy is given, that eat up the nuclear area, and this was also confirmed with the histopathological finding. This is in the virtual stain how the seeding looked. And in histopathology, there was anterior chamber involvement was seen anterior surface involvement of the cornea, and ciliary processes were also involved. And you see in higher magnification, there was a iris involvement was seen in the anterior side. The tumor is necrotic. As we know, the chemotherapy was given in the patient, and subsequently the portion of the retina was tumor was seen arising, the preretinal seeds and the central RP atrophy in monolayer were also seen. Photoreceptor degeneration were also evident. Lateral calot did not show the tumor, and cut end of the optic nerve, no tumor, but the atrophic changes were noted. So in histopathological diagnosis, what is important, it was an endophytic, corneal stromal involvement, and chemo-induced RP atrophy and other things were seen. Histopathological grading was G4, and AGCC pathological classification was PT2B. Now, prosthesis was given in the patient. Metastatic workup was done by oncologist. Patient is currently on follow-up on medical oncologist at the local cancer hospital. Second case is also very interesting. It's an 8-year-old from southern part of northeast India, the state Tripura, complained of progressive diminution of vision. Family history showed bilateral retinoblastoma in a elderly boy who is 2 years, and there was a 4 years prior from this patient. Visual acuity was normal in the right eye, perception of light in the left eye, and IOP was raised again in the left eye, and no lymph and adenopathy was seen. This is ectropy and UVA and neovascularization and seen. And you see, when we saw for the first time, it was appearing as a xanthophilic lesion with the blood vessel, but there is no telangiectatic vessel, giving a differential diagnosis of a Coats disease. But when B-scan ultrasound was done, there was there was a laterally spreading tumor was there, but there was no calcification detected. This patient also, because of a diffuse retinoblastoma, enucleation of the left eye was suggested. This is the eyeball we showed. Now this is how generally we do a site determination of the tumors. This is how the enucleated eyeball examined in the pathology lab, and different measurements that are being carried out. And this is the proceeding of consciousness meeting from international retinoblastoma staging, how the lateral calots are being made, and this is the way how the central calot and the lateral calots and cut end of the optic nerve are seen. These are the lateral calots which we have to see meticulously in retinoblastoma for this. And coming to the patient here, you can see the diffuse involvement of the retina by the tumor, and the maximum basal diameter was 6 mm, height was 7 mm, thickness was 5.5 mm, percentage of vitreous cavity involved around 45%, and distance of the anterior edge of the tumor was 0.4 mm, and distance from the posterior edge of the tumor to the optic disc was 1 mm. These are again you see in the raw specimen seeding along with the blood vessel which are being evident there. Again the central RP atrophy which was seen in the fluorescent stain in raw specimen. Photomicrograph of the normal cornea was seen here, and angle of the anterior chamber was normal, and this is the iris portion was also normal. You see the tumor retinoblastoma blue cells, basophilic cell arising from the retinoblastoma, which is very important, and the cystic changes which are being seen. This is the higher power of the same photograph. You can well appreciate cystic spaces in between retinoblastoma. These are the exudative area and the cystic changes that has been seen. These are the undifferentiated retinoblastoma proliferation in low power. This is in the high power of undifferentiated retinoblastoma. Lot of necrosis was seen in this tumor, and there was no choroidal involvement in the lateral calots. Photomicrograph of the cut end of the optic nerve was free from the tumor, and this is the cut of the optic nerve which showed a free from tumor. So this is again a diffuse infiltrated retinoblastoma was diagnosed, undifferentiated, and grading was G4, and AGCC8 pathological staging or PT1, and there's a hereditary factor of H1. So retinoblastoma is the most common primary intraocular malignancy in childhood, occurring in 0 to 3 years of age. No sex predilection of in India around 2,000 cases per year is seen, and 25 to 30% case can be bilateral. We see RB1 mutation in some cases, and in younger patient we see MYCN mutation in 3% of the cases. 60% are sporadic and 40% are familial. So what we understood in this case was that both the cases were atypical, and first one has anterior segment group E retinoblastoma with histopathological high risk factor. Second one was diffuse group E retinoblastoma without a high risk factor. Familial involvement was seen in second case, and anterior segment deposit did not respond to systemic chemotherapy in the first case. Gross and histopathological study in those atypical retinoblastoma was important. Pearl in diffuse RB, it can mimic other disease, particularly uveitis, can sometimes causes misdiagnosis. Pseudohypopion, iris color change, SC flare cell hemorrhage are important. Mean age around 5 to 7 years, and usually male are more than female, unilateral more than bilateral. For positive family history can be seen in four cases in out of 77 cases in the publication by Train et al. And symptoms include decreased vision 48%, redness 45%, pain in 35%, leukocoria in 24%, whereas 60% is seen in other RB, discoloration of iris in 14 cases. In signs, vitreous cells in 79%, pseudohypopia in 48%. More than half of the cases can be wrong diagnosis with subretinal fluid, iris neovascularization, cataract, retinal detachment, uveitis, toxocora, endophthalmitis, and trauma. Absence of mass and calcification, growth spread is slower, and RB gene mutation in Train et al. Study was seen in around 3 out of 4 cases. So thank you for patient hearing. Any question? I think Hanover sir is there. Any question from? Thank you.
So, Dipankar, there's a very nice histopathologic demonstration, and there is a clinical correlation. One of the point I want to highlight that retinoblastoma remains in the children mostly, but there are reports, and we have reported 2 cases of adult retinoblastoma. So keep your mind open, and if the features are suggestive of retinoblastoma, that like whitish mass lesions, seeds, do for the vitreous biopsy or fine needle aspiration biopsy, and just confirm, and then may require enucleation or other forms of treatment. So adult retinoblastoma is an entity, so it's not the retinoblastoma occurs in the children only. And as you have shown, the diffuse infiltrating retinoblastoma is a real challenge. Ultrasound becomes a non-calcification, but if you have got UVM and anterior segment OCT, you can pick up.
Thank you so much, sir. So we are almost in time. If you have any questions for Somashila, I think she's not there. So thank you, JV sir. Thank you, Somashila. Thank you, Rima, Ubaid, everyone. Thank you, everyone. So we conclude the session. Thank you.
I'd like to thank AIOS Scientific Committee for selecting this one. Ophthalmic pathology, as is told, as is our pathology, so is our practice. So as the ophthalmic pathology, so would be our ophthalmic practice. We may understand a lot of pathogenesis of many diseases and characteristic features of these diseases, which may make our clinical work more interesting, more pleasant, and more meaningful.
Thank you, sir.